I remember being in that spot in school, and it just, weekends get kind of crazy, but I promise eventually you will get your weekends back. Weekends are always a little easier for me because during the week, I am a full-time dermatologist, full-time new mom. And so I appreciate you guys taking your hour to be with me here on Saturday. So hopefully I can, provide some guidance as to what dermatology is about, kind of how my path into getting here was, and maybe a little bit of education. I know a lot of you have already had some dermatology lectures. So hopefully, there's a little bit of new stuff, but definitely want to leave room for questions. So as they were just kind of explaining, if there are any questions on just how to get into dermatology, what we do, different paths within dermatology, please ask away, because I'm very passionate about kind of how I got here, and I love what I do. I think a lot of us physicians feel that way, but maybe not all specialties. But I know dermatology, every dermatologist would probably say if they could do it all over again, we would do the same thing. So I'm very passionate about what I do, and would love to help any of you that feel the same way. So let's just get right into it. I now will share my screen, and I'll just get started. And then, like I said, if there are any questions, I guess we'll just leave them for the end and go from there. First of all, here is my contact information. Dr. Mislankar at gmail.com is probably the easiest way to reach me, or my Instagram handle. Social media has definitely run amok with skincare influencers right now, but there's a lot of us physicians that are getting on it. And if anything, I'm actually a little late to the train. So I just joined a couple months ago. And I think it's been really great to see some of my other colleagues on there providing, real skincare advice, kind of myth busting, if you will. But if you need to find me, I'm on there also. So you can definitely direct message me or just email me if there's any questions after this about anything related to medical school or dermatology in general. So how did it start? For me, right after high school, I've always lived in Ohio. So I actually went to the Ohio State University. I did 4 years of my undergraduate there. My major was in molecular genetics. I got my bachelor's of science in that. And then I also did a Spanish minor. I always knew that I wanted to go into medical school. So I was hoping that the Spanish minor would help me, depending on, if I settled anywhere where there were a lot of Spanish speaking patients. I will admit I don't use it a whole lot up here in Ohio, but occasionally I do. And I think that it was a relatively easy thing to get at Ohio State. So I don't regret doing that at all. After that, medical school, that was another 4 years. I came down here to the University of Cincinnati for College of Medicine. That's my husband on the left. He is from Cincinnati, which is why we are kind of based out of there now. And he went to law school at the same time that I went to medical school. And then some of my really good friends from medical school there on their right. So one of them is a practicing anesthesiologist now out in San Francisco. And the other one is also in California. And she is a pediatric allergy immunologist. So there were a lot of my classmates that were from California, because Ohio has a lot of medical schools. And so just, when they were applying, I know all of us were applying very, very broadly. I got fortunate to stay close to home, but we had a lot of, classmates from California. So after that, for dermatology, you can either do, you match your 4th year of medical school, and then it's a 4-year residency total. So it's either a preliminary year or a transitional year. The differences mainly are preliminary years are in general usually classified as harder. Now, that obviously is going to be program specific, but you can do a medicine year, you can do a surgery year, and then a transitional year tends to be a little bit more elective time. So a lot of my friends that did do transitional years had a few months on the wards, they had a few months of surgery, and then they had a few months of more electives. Whereas my preliminary year, I did it at Case Western, and it was a very, very hard year. Why did I do that? I did it mainly just in case I didn't match dermatology. dermatology is one of the harder specialties to match into. And that was definitely something that I was, worried about and just wanted to set myself up just in case it didn't work out. And so I felt that by having a preliminary year before I went into dermatology, being at such a prestigious university, it would set me up to be a little bit more, ready if I needed to reapply to kind of show that I did 12 months of a rigorous program. So luckily, I matched and did not have to take a gap year. And you know what? I feel like I learned a lot that year. A lot of what we do in outpatient dermatology, as you'll see, I left the PowerPoint to kind of some of the basic stuff that we do day to day, but there are conditions where we're seeing blistering skin disorders and things that need a lot of medical management, IV drugs, et cetera. And so I do think that that year set me up for that really well. So I don't regret that at all. But, and then dermatology residency. So dermatology is a 3-year program. I did mine at the University of Florida. That's where I matched down in Gainesville, Florida. And here are my amazing co-residents the year that I was chief resident. So in our program, we had 4 residents per year. Right before I came, there were about 2 residents per year. So there were 6 total in the 3 classes. And then by the time I was there and I was chief, there were 12 total. So you'll find programs that are 2 residents. There are larger programs. I know like Emory in Atlanta is pretty big that are 6, that are 8. So it really just depends on where you go, but the size can vary. And in terms of residency, we do so much. So basic science is a big portion of it. Obviously, general dermatology. So your acne, your psoriasis, all that falls into general medical dermatology. We do a lot of complex medical dermatology. So that's going to be your blistering disorders, your autoimmune disorders. A lot of dermatology residency is doing inpatient consults, probably no matter where you go. So our residency was mainly outpatient in the sense that our clinic was off of the main campus. So it was nice to kind of get that feel of the outpatient setting. But there were, definitely months where we were on call for the VA or the main hospital. So we do a lot of complex medical dermatology. We learn pediatric dermatology and basic surgical dermatology. So that's going to be your excisions of cysts, scars, keloids, non-melanoma skin cancers, melanomas. And then we do a lot of Mohs micrographic surgery also. So I'll talk a little bit about that on my next slide about the possible fellowships. But even if you don't do a fellowship after dermatology, you spend a lot of time during residency, working with the attendings on Mohs surgery, which is really important to kind of hone in your surgical skills. That's one of the things that I loved about dermatology was that I could basically still do procedures without having to be in a surgical OR setting. And more importantly, I didn't have to get any extra training. It was built into my 3-year residency training. Other stuff that we do is oncology. So again, melanoma and non-melanoma skin cancers are our most important aspect, I would say. I see melanomas all the time where I'm excising them. I'm working with hematology oncology, surgical oncology to get these patients, whether it's chemotherapy or a surgical excision in the OR, but, we work as a team. Laser and cosmetic surgery is a big part of our training, and I really enjoy it. So it's part of my practice on a day-to-day too. But where I trained, we were fortunate to have about 9 different lasers that do a lot of different things. So that was part of our training. Again, cosmetics, you're doing Botox, filler, acne scarring. But, cosmetics and aesthetics is a really large field of dermatology right now. So dermatopathology is a fellowship also, but we learn all of that. It's a big part of our boards, and it's really important to know what the pathology is under the skin. We have to, it's not something I do on a day-to-day. I don't look at derm path anymore, but during training we do, because it's important to learn what it looks like under the microscope for us to be able to know what it's going to manifest as on the patient. Derm pharm, so lots of medications. I think one of the myths about dermatology is that all we do is prescribe steroids, and we use a lot of steroids, but that is definitely not all that we do. There are many, medical management that we need to do with certain conditions, biologics, et cetera. So that kind of gets me into immunodermatology, and then phototherapy. So there's, you'll see in my presentation, there's a lot of conditions where we use things like UV light, blue light, red light for acne. And so that's part of training as well. All right. And then after residency, so I did not do a fellowship. I am a general dermatologist. And like I said, you are able to do surgeries with that. You're allowed to do lasers, cosmetics, all of that is built into our 3-year residency. But different fellowships that exist if you wanted to subspecialize are Mohs micrographic surgery, pediatric dermatology, derm path, and then some of my colleagues have gone on through the ASDS, which is the Society for Derm Surgery, and done specific laser and cosmetic procedures to do even more high in-depth kind of training on some of these techniques. And then board certification. I posted this photo of my graduating class the day that we all found out that we passed our boards. So board certification is huge for any specialty. Dermatology boards are very, I don't know if they're very hard or if we're just very type A, but all of us treat it like it's bigger than the MCAT, like it's bigger than the boards. I thought I studied so hard for the MCAT. I thought I studied so hard for my boards, my USMLEs. And then I ended up studying 10 times harder, I think, for my board certification, because we were finally at the end of the journey and you don't want anything to mess you up at that point. So everything that you learn, the 3 years of residency set you up for that. A good program will get you ready for that. And so we took the boards at the end of a month after we graduated residency, before we all started working, basically. And you'll see a lot of us physicians, especially dermatologists, to stay saying, claiming that we are board certified dermatologists. So why is that important? I think in the time that we are right now, where you see a lot of med spas opening up and a lot of people are doing Botox and cosmetics and surgeries, it's important to know, as a client, as a customer, as a patient, kind of who is doing your procedures. Are they well trained to do so? To become a board certified dermatologist, you guys will see as soon as you start medical school, and even before, by doing hours like this, you see we have about 12 to 16,000 hours of patient contact hours by the time you're done with all of this, which is an insane amount. And so, if you go into aesthetics, you don't go into medical school, you do weekend courses, it's just not the same. You want to go to someone who is trained in these things, because complications can happen. And so I think that you'll see a lot of physicians that are saying that they're board certified, and that's what it means. It means that they graduated from a residency that was ACGME accredited, they passed their boards, and that's why you'll see that after most of our names. So that's how it started. How's it going? As they introduced me, I am here in Cincinnati, Ohio. I am a private practice outpatient dermatologist. So I work 4 days a week. Dermatology is great for work-life balance. I have friends that work 3 days a week. I have friends that work 5 days a week. I have some colleagues that own their own practices and they work 6 days a week. So, it just really depends on what you want to make out of it. Do you want to be inpatient? You could work at an academic center. You could work with inpatient consults. You could primarily just do outpatient like I do. On average, I see about 40 patients a day, which is a lot. But it is definitely manageable if you have the right staff, which, I credit a lot of what I do to my staff. They are just great. They know, they're kind of like my second hand at work. They kind of know what to anticipate, what's coming up. So that's why I'm able to see as many patients as I do. I do adult and pediatric patients. And again, I do general, cosmetic, and surgical dermatology. A lot of my colleagues kind of they have a mix of a day. So in one day from 8 to 5, they may, see a couple patients, do a surgery, et cetera. I prefer to do kind of my general days, and then I like to have my procedural days. Now, dermatology is highly procedural. So even on my general days, I'm doing biopsies all the time. But by that, I mean, I like to keep my, for example, for me, Tuesdays are my surgery day where all my surgeries are scheduled. I'll have cosmetics kind of throughout the week, but then I have a special laser clinic on Thursdays. So that's kind of how, an average day works for me. And then recently, one of my co-residents, actually, she was in the last 2 photos, but we met during residency and we became best friends very soon after. We always dreamed of starting our own skincare line. And so we just launched that in September. And so not working on Fridays in clinic has given me the opportunity to, again, work-life balance and, be able to do this on the side. So that's kind of one of the main things that I love about dermatology. I love that it's procedural. I love that I can see adults. I love that I can see pediatrics. I think every day is so diverse. I see so many different things. You never know what you're going to get on any given day. And the work-life balance was important for me. I knew that I liked surgery, but I did not want to be into the OR. But this allows me to still have a family. I met my husband when I was in undergrad at Ohio State, and we've been together since then. And then we just had a baby this year. So it kind of allows me to still be a full-time physician, but, allowing me to work on some of my other stuff as well. So let's get into dermatology, and then I'm happy to answer any, why derm or how to get into derm questions later if you have any. But let's start with the absolute basics. So basics of dermatology, there are 3 layers of your skin, and this is important to kind of figure out. We'll get into kind of naming certain skin conditions, but you have your epidermis, and then you have your dermis, and you have your subcutaneous fat. So the majority of, this photo is the epidermis. So there are 5 layers to the epidermis. The epidermis is going to be your barrier. It's going to be your first kind of mechanism to like keep all the good in, keep all the moisture in, and keep all the bad stuff out, infection, etc. So there's, and this is kind of, important to know when we start looking at derm path and derm residency, because you'll see a lot of different pathology that pre-cancers, cancers that are, depending on where they are in this, will tell us a lot about that person's condition. So basics of dermatology, and we have like our own language in dermatology, and a lot of the other fields definitely make fun of us for this, but it's important. And once it's something that you guys will learn in medical school and you will use it throughout. But bulla is a easy way to say, harder way to say blisters, but that's basically what it is. It's a collection of free fluid. A macule is one of the most common ones that we use. So the next picture, the second brown one right there, the macule is going to be something that is circular and flat. It can be any color, but basically it's a flat lesion. So from macule, you actually go over here to patch. The only difference between a macule and a patch is the size. So macule is anything under 1 centimeter and patch is anything greater than 1 centimeter. Next, I like to do actually papule and plaque. Papule is going to be something that is elevated. So that's what already distinguishes it from this macule. Macule is flat, papule is raised. And then the difference from this is papule to plaque is the same thing that we did up here from macule to patch. So a papule is going to be less than 1 centimeter actually, but usually less than 0.5. And a plaque is going to be greater than 1 centimeter. So for example, acne bumps are going to be papules. Psoriasis is going to be a plaque. Certain birthmarks are going to be macules or patches. So other things are nodules are going to be your cysts, your skin cancers. That is anything that's very large and elevated. Pustule is, again, a great way to describe acne if there's actually pus inside of your bump. And then vesicle is another smaller way that we basically describe a blister. So lots of terminology that we use. This is more what I call secondary characteristics of dermatology terminology. So a wheal is a fancy word of saying a hive, urticaria. If you're allergic to something, you're going to see a wheal. That is a transitory lesion filled with edema. So that tends to eventually kind of go away. Scale, crust. So that's when you see that thickened skin on top. Psoriasis has that. Eczema can have that. Crust tends to be, more yellow in nature. You have your excoriations. That's going to be any sort of kind of linear, cut in the skin, etc. So certain types of eczema can show us that. And then erosions are going to be where you actually have a loss of epidermis. So eczema is going to do that. A burn can do that. Lichenification is something we can see in many different dermatology condition. So eczema, psoriasis, what does that tell us? It's basically a thickening of the epidermis. And that is when you see that something has been around for a long time. So no longer is it acute, but it's actually a chronic condition. And then a scar, you can have scars from skin cancer surgery, you can have scars from acne, so lots of different things that can cause scars. And then all of these are, again, ways that we in dermatology kind of use our terminology. So you can have eczema that is, you can have a contact dermatitis, for example, that it has a very sharp border. You can have something that's an ill-defined border. Serpiginous is going to tell us that maybe it's more fungal, like a tinea corporis. So the point of all of this is, you know, you don't have to remember any of this yet, but it's just that dermatologists tend to use a lot of this different terminology, and it's because they're like buzzwords to us. If you tell me that you have a serpiginous erythematous annular lesion, that automatically tells me that it's probably one of three things. Is it a fungal infection? Is it something called granuloma annulare? So if you go into dermatology, you definitely want to be able to have visual recognition pattern. That's really important. And then helping describe what these terms kind of like helps hone it all in for us also. Again, all of this is going to help us with our differential diagnoses also. So, you know, just overall finding out, is it localized? Is it generalized? Is it symmetric, etc. So, basically, I figured the best way to kind of shadow me virtually would try to just see what's on a general day for me. Some of these are patient photos. Some of these are from our textbook. I would love to have you guys in person, but, you know, this is a great way to do this until then. So Monday morning, we walk in to general dermatology, and I have my 40 patients on my schedule. And so what do I have? We have skin checks. I have a couple spot checks. I have a few rashes, some acne scarring, a few cosmetic consults that are always fun in the middle of that, and then hair loss and some scarring treatment. So let's get into
It's a hard way to say blister.
Let's get into this one. Oh, sorry. Do you need me to? Let's get into this one first. So skin check. This is the majority of what I do. Out of my 40 patients, I would say I see probably at least 20 patients a day that are for skin checks. So we have a 75-year-old Caucasian male with a history of malignant melanoma and non-melanoma skin cancer. He's had a basal cell before. So he is currently on a 6-month skin check schedule, and he presents for a full body skin exam. His chief complaint is, hey doc, I have all of these pink scaly areas on my scalp. On top of that, my wife actually circled a really dark brown spot on my back. She's really worried that it's another melanoma. So what are these pink erythematous scaly plaques on this patient's scalp and forehead? So pink is pink. Erythematous tells me that it's red. Scaly is that photo that I showed where there's a little bit of elevation here. And then I would call this a plaque because it's larger than 1 centimeter and it's raised. So that's why I kind of went into some of the terminology. But are these basal cells? Are these actinic keratoses? Is this psoriasis, or is this an amelanotic melanoma? So I will just kind of click through. These are a classic example of actinic keratoses. So I see these all day, every day, really, really common in patients with chronic sun damage. And basically, what are they? So they are a pre-malignant lesion that can eventually turn into a squamous cell carcinoma, which is the type of non-malignant, non-melanoma skin cancer. So can present as papules. So that means they can present as kind of like raised bumps or plaques. They are often hypertrophic. So I didn't talk about that. What does that mean? That means you have a really large kind of like bump, and then you have that large crust on top of it. So it's going to almost look like a little horn sometimes on patients, like a cutaneous horn is what we call it. They don't have to be treated. You know, I explained to the patient that they are precancerous, but that doesn't necessarily mean that they are scary. They don't need to go home and get worried that they have these. But we do often treat them because a lot of times they're painful for the patient, and overall having multiple puts you at about a 10% higher risk of having a squamous cell cancer. So often we do treat them. How do we treat them? Probably the number one way is with cryotherapy. So sometimes we'll refer to that as cryosurgery, cryotherapy, liquid nitrogen, negative 196-degree liquid nitrogen that is sprayed onto the patient. A lot of times, if they're all over the forehead, in this picture, actually, I would probably do topical chemotherapy. That can come as a chemotherapy that's in a tube. It can come as something that's in a packet, but it's basically something that the patient applies for a few weeks at home, and then we see them back for follow-up. Or phototherapy. So a lot of offices will have something called blue light therapy. So a patient comes in, they get a medicine kind of painted all over their scalp, and then you sit under a blue light, and basically that treats them also. So lots of different ways, but see these all the time, treat them with cryosurgery all the time. Very, very common thing in my practice. So then my wife circled this brown spot right here. She's really worried it's a melanoma. What do you think it is, doctor? It's so dark and it's so black. So is it melanoma? Is it basal cell? Is it a seborrheic keratosis, or is it a squamous cell? So this is a seborrheic keratosis. I apologize if you guys have already had these, and these are really easy, but just kind of, you know, this is something I see all the time. A lot of patients don't know what these are. They get very, very scared because they are really, really dark. They're black, and they were told that it could be some, you know, black means melanoma. But, you know, dermatology is so much about pattern recognition. And so I can look at this and just know that it is a seborrheic keratosis. And what does that mean? So that's a benign epidermal growth. It has no way of turning into skin cancer. It can be pigmented. So it often is pigmented. It's brown, tan, black, dark brown. It kind of has a waxy look to it. So a lot of patients will call them barnacles. They'll call them warts. But when you look, hopefully you can see in that second bottom right picture, but kind of looks like it has a little like waxy kind of crust to it. We call it a papule because it's raised. Oftentimes you can have plaques. These do not need to be treated at all. There's no reason to treat them. They're not going to turn into skin cancer, but we often do treat some of them when they become irritated. So a lot of times they'll become red, they'll become itchy. Patients will say they're getting caught on their bras, it's getting caught on their seatbelt, they're hitting them in their scalp when they're, you know, brushing their hair. So often they'll come in for that. We do treat them. I often treat with liquid nitrogen, or we can do something called electrocautery, which is a procedure. Basically, it's electricity that we kind of like burn them off, if you will. Or sometimes if they're really large, I'll actually numb them up and remove them by shave removing them. So a lot of times, some of my younger patients will get them and they don't like how they look cosmetically. So we will take them off, but they don't need to be done. So for this patient, as we do so often, I usually say that they are either, I call them maturity spots or wisdom spots. And that always, you know, makes the 75-year-old man always laugh because we don't want to call them age spots. And we kind of joke it off. And, you know, I tell him, hey, go tell your wife that this is nothing to worry about. It's not going to turn into skin cancer. So next patient is a spot check. This is a 65-year-old guy. He's never had a skin cancer. He's a new patient. He doesn't like going to the doctor. He's never had a skin check before. But, you know, again, his wife probably sent him in. He has this spot on his face and he thought that it was a pimple, but now it's been there for about 3 months and it's not healing. He wants to know if I can take it off. So what is the most likely diagnosis for this patient's spot? Is it a basal cell carcinoma? Is it an actinic keratosis? Is it a squamous cell? Or is it a amelanotic melanoma? So this spot right here was a basal cell. So basal cell, there's a lot of different kinds. You have superficial basal cells, you have nodular, all of these are different ways that we call them depending on what we look at them under the microscope. So who gets basal cells? Risk factors are patients with fair skin, those that have a lot of UV exposure, tanning bed exposure, immunosuppressed patients, patients with history of cancer and radiation. But the big thing is leisure time in the sun, meaning, you know, one big bad sunburn could put you at a higher risk, of course, but it's usually our patients that have a lot of sun exposure. Once you've had one, your risk of having a second is 40% over the next 5 years, which is pretty high. So once you have this, we definitely like to encourage these patients to kind of come in annually for skin checks. We are seeing younger and younger patients with this. So, you know, in this example, I think I said a 65-year-old guy, but I see 20-year-olds all the time now, 30-year-olds all the time. So definitely, you know, a big part of what I do is discuss sun protection and SPF with all of my patients. But how did I know that this was a basal cell? Well, that picture, it was kind of pink. It was what we call pearly. You'll see that photo on the top right. It has telangiectasias, which are blood vessels. So all of these are different forms of basal cell. You can see how the top right one actually looks like a little patch of eczema. The bottom one looks more like a scar. So this is something that with training, you will just get good at recognizing because you'll see so many of them. But, you know, for this patient, one, he wanted it taken off, and two, we needed to figure out what exactly it was, pathology-wise, right? So this is an example in clinic where we do a procedure right away. My, you know, nurse will numb him up. I will take a little blade called a derma blade, and I will shave it off, and then we cauterize it so it removes it for the patient. We send it to be looked at under pathology, so that's our biopsy. And then depending on what it is, it will need further treatment. I always tell the patient that a biopsy is only diagnostic. It's not actually a treatment. So afterwards, to treat it, depending on what kind of skin cancer it is, these are all the different procedures that we can do. We can excise it. On that one, on the face, I would send it to be treated by a Mohs surgeon, which is a special type of dermatology surgery where it's more localized, it's tissue sparing, and especially for that guy, it was on his face. The really, really big ones, if it's involving your entire ear, I had a patient last week who it involved this much of his ear. It went all the way back into his scalp. It had been there for about 5 years. We sent him to radiation. This top one right here, small eczema patch. I can do liquid nitrogen on this. I can do topical chemotherapy on this. So lots of different options. The really, really big ones, I haven't had to send this in a while, but there are some genetic conditions where, you know, we see like 15-year-olds, 20-year-olds that are covered in these, you know, 50 of these, hundreds of these. They are going to go to my hem-onc doctors and get chemo. So while we're on skin cancer, so what is the most likely diagnosis for this lesion? So this looks a little bit different from the last one I sent you. There's a little bit of crust in the center, but again, we're gonna biopsy to find out for sure. But just looking at this, out of all of these options, I would definitely think that this is mainly something called a squamous cell carcinoma. So usually the big difference between basal cell and squamous cells, these tend to be a little less pearly looking. A lot of times they have this kind of crater in the center. They look very volcano-like. These grow very quickly. So basal cells can last for 3 months, 4 months, 5 months, years, and slowly grow. This specific type of squamous cell, which is called a keratoacanthoma, grows quickly, meaning my patient will say, I just saw you last month. I went home a week later, this started on my leg and it is just blown up. So this is the second most common type of skin cancer, something I see multiple times a day in clinic. It's classically a raised crusted lesion that just won't heal. These have the potential to metastasize. So it's not common, not like melanoma, but the ones that happen on the mouth, you know, the lips, inside the mouth, the ears, the genitals, definitely more likely to metastasize. So one, we definitely want to see these. And we want to refer these out if they need any sort of imaging or chemotherapy, but that's rare. You know, in the last 3 years, I've only had a few that I've had to send, and those were patients that had had their spots for a couple of years without getting them taken care of. Incidence of these has really increased to about 200% in the last 3 decades. So, you know, all types of skin cancer are on the rise right now. Specific risk factors for squamous cell. This is not my photo, but this, you can see this one on the lip right here, which has probably been there for a few months, maybe even a couple of years. organ transplant patients are at a much higher risk of getting skin cancer, specifically squamous cell. So we'll get a lot of referrals in dermatology, especially when we were in residency, inpatient for patients who were set up for liver transplants, kidney transplants, to do skin checks prior to starting. Specifically, chronic lymphocytic leukemia patients are at a higher risk, and then your heavy sun exposure patients. So this is really where those blistering sunburns can come into play. So next patient is a 35-year-old Caucasian pregnant female. She's never had a history of skin cancer, but definitely used the tanning bed a lot as a teenager and in college. She's a new patient, never had a skin check before. She's noticing this mole for a while. It's on her stomach, and it's growing really quickly, but she thinks it's probably just because she's pregnant, but decided to come get it checked out. So what do we think is the most likely diagnosis for this lesion? SK, benign nevus, or mole, melanoma, or is this a pigmented basal cell? Because you can get those too. So looking at this, I was definitely worried about a melanoma, and so we biopsied it, and that is what it ended up being. Melanomas arise from melanocytes, so that is going to be the cells within that epidermis, that first photo that I showed you. They tend to be at that bottom layer of the 5 layers of the epidermis, and those are the cells that give our skin its color. Everyone here has probably heard of melanoma. We know that it's an incredibly deadly form of skin cancer. So unlike the other two, which are very important to diagnose because they can be disfiguring, they can lead to a lot of local issues. Melanoma is important to diagnose immediately because this can spread rapidly within weeks, months, to the lymph nodes, to the internal organs, to the brain. I remember my preliminary year when I was on the oncology rotation, how many young patients we would see, just healthy, 30, 40-year-old guys that presented with seizures, and they found out that they were, because they had brain mets from melanoma. So it's really important to, we emphasize this all day, but sun protection is important. If you weren't good about sun protection when you were younger, like get in with a dermatologist, get your regular skin exams. But about 50% of the time, this starts in a pre-existing mole, or it can come out of nowhere, come in from a new mole. And so the reason I made her a pregnant, she was a pregnant, in this example was pregnancy is common to see moles change. But it's also a time where, you are in one sense immunosuppressed a little bit. All of your body is going to fight off for this baby that you're trying to grow. So, your checks and balances are off a little bit. So we definitely do see melanoma arise a little bit more in someone that is pregnant. That doesn't mean being pregnant predisposes you to melanoma. It's just more like if it's already in your genetics, it might be something that you see at that time. So overall, melanoma accounts for less than 5% of skin cancer, but causes the majority of skin cancer deaths. But unlike many other cancers, this happens in your younger and older patients. One of the more common cancers in young adults, especially young women. So I'm going to start going a little faster because I think I forget how much time we have. But melanoma ABCDEs. So these are kind of some of the things that we look out for when I'm looking at a lesion. So A is for asymmetry. One half does not match the other. So you can see in this example, if I make a line down the center, the left does not match the right. So basically this is definitely worrisome for melanoma rather than a normal mole. Border. We like our nice circular moles. This is a scalloped, kind of ragged, irregular border. So something that if I saw this, I would definitely want to biopsy this. Color, this is the first picture. Again, this is asymmetry, but color also. If I were to draw a line, this side does not match this side. This side is dark. I see a lot of black in this. This side is more tan. So another reason to biopsy. Diameter, we always say greater than the size of a pencil eraser. So about 6 millimeters. If you've had a mole your whole life that is bigger than 6 millimeters, you do not need to freak out. That does not mean it's a melanoma, but more so a new mole after the age of maybe 25, 30, that is this large. Now, my SKs that I first showed, those were probably bigger too. So size is not, anything to necessarily just off the bat be worried about, but it's more any sudden or continuing increase in size. And then evolution is probably the easiest. Patients are going to notice, or we hope that they notice when they start off like this and they start to change. So this is something that I always ask a history for. Is it changing? Can we notice that it's changing? So let's get into some rashes. I see follow-ups for rashes all the time. I get consults from, primary care doctors for rashes all the time. And I see new consult like urgent rashes all the time. So what is the most there we go. 6-month-old boy, he comes in with his mom and he has this new rash on his face. No other medical history. It's really, really, really itchy. And the mom is super nervous that he's actually allergic to something. So what is the most likely diagnosis for this? Is he allergic to mom's breast milk? Is this psoriasis? Is this a bacterial infection? Or is this atopic dermatitis? So this kiddo right here actually has atopic dermatitis, which is a, again, fancy word for eczema. So eczema is kind of a wastebasket term for any dermatitis. Dermatitis is going to mean your pink, scaly, kind of itchy rashes. So atopic dermatitis can be in that. That's the genetic one that I think is most often referred to as eczema, but allergic contact dermatitis to poison ivy can be a eczema. Lots of different reasons to call something eczema. So characteristics of this is it's very, very itchy. We call that pruritus. It's chronic. So it usually begins in infancy, but occasionally can happen in adulthood also. And has what we call the atopic triad. So a lot of these patients were also predisposed to asthma and have food allergies, but that does not mean that this is because he's allergic to something. So this is eczema. He is not allergic to his breast milk, but does that mean that he's having eczema in his genetics? He may be higher risk of being allergic to eggs or et cetera, but those allergies are not causing this rash. So that's really important for me to tell those moms, is that, this is not caused by something she did or something that he is eating, etc. Acute lesions. So fresh lesions are going to be pink, scaly. They can be raised. They're often raised. They are always raised. They are either going to be small bumps or they're going to be larger plaques. You can see yellowing and crusting of this, and that's usually because eczema can actually lead to secondary infections. Your chronic lesions are going to be more this top picture. This is where I say lichenified, and you can see pigmentary changes. So in my Caucasian patients, I often see hypopigmented spots. In Indian patients like myself, in African-American patients, I'm going to see more hyperpigmented spots. So it can leave brown areas, pink areas after. On kids, babies, it's usually on the cheeks, scalp, neck, and then it usually is on their arms and legs. Kids, usually here, kind of like right here in this crease of the elbows, right behind the knees. And then on the adults, they can get it in all of those areas. But a lot of times we see that if they grow out of it at some point, it tends to be more on like the nipples and the hands and the feet, for example. Usually this spares the diaper. So, that's a talk for another day on diaper rashes for kids. But usually atopic doesn't tend to involve the diaper. Treatment options. So lots of treatment options. Gentle skincare recommendations is something that we spend a lot of time going over with the mom and the parents in general, but no fragrances, really gentle skincare recommendations, detergents, Vaseline, emollients, etc. We use a lot of topical steroids here. This is the mainstay to treatment. So we tell mom that it is not scary to use topical steroids. She does not have to worry about them, getting any sort of systemic absorption. Really bad patients, sometimes occasionally we do oral or intramuscular Kenalog, but that's not something that is obviously something that we can keep patients on. So sometimes that's more of just like a really quick treatment while we get some of these other options started. So you can do phototherapy for this. And then the last couple are more some of the medications that I was talking about, methotrexate, Dupixent. Those are more biologic type, systemic type treatments that it's really nice to have a good medical background, because a lot of those require lab monitoring and et cetera to make sure that the patient is controlled. So and antibiotics, we don't treat eczema with antibiotics, but again, some of these patients can get secondary infections. So those would have to be on antibiotics. Next rash that, again, see a lot of rashes in clinic. This is a 55-year-old female. She has a long-standing history of a rash that is on her elbows and knees. She thinks her aunt has a similar rash, but she's not really sure what she was diagnosed with. But now she's starting to get some joint pain in her fingers and knees. And she comes in because she said, every summer my rash usually gets better, but now it's not really responding to any of my normal treatments and my joints hurt. Do you think this is related? So this rash right here is, it's not eczema. She is not infected, and no, she is not allergic to gluten, but this is psoriasis. Psoriasis can look like this, where you just see little plaques on the elbows and knees. It can look like this, where it's smaller areas all over, but we describe this as erythematous papules and plaques with a silvery scale. So that silvery scale tells me that it's, you know, oftentimes something like psoriasis. So you can see how right here, there's these little areas of bleeding. That's called the Auspitz sign. It's when it bleeds, when the scale is removed. Psoriasis is definitely a pattern recognition also. In this case, it's everywhere, but a lot of times it's on elbows, knees, but on the front. So not the crease like atopic dermatitis, but here. It is on your scalp. It's right around the belly button a lot of times, and kind of in that like gluteal crease. You can see nail changes, you can see hands, you can see feet. Important thing to tell these patients is that this is not infectious. They are not contagious. Their kids are not going to get this by touching this. Their coworkers do not need to be nervous about this. But, you know, a lot of times patients are really embarrassed by this. And more importantly, a lot of times it's associated with psoriatic arthritis, and that is a deforming arthritis that actually changes your joints. And so we need to, you know, get this diagnosed and get this treated quickly. Treatment wise, so a lot of times we're going to use topical steroids here too, and then biologics. So all those commercials that you see about Humira and Skyrizi, I don't know if you guys have noticed those commercials, but you know, it's like the patient that's really embarrassed by their psoriasis. They're in the grocery store, and then they talk about this medication, and they're jumping through the fields, and they're super happy that they're cleared. But those medications work. They're injectables and something that we prescribe all the time. So, you know, classic case of where we're not just doing topical steroids, but we're doing actually, you know, heavy duty kind of medical monitoring. But patients get a really, really good quality of life, and overall pretty safe. So acne, I see a lot of acne. You know, acne is something that definitely is very common in the Western world, and something that a lot of us dermatologists do on a day-to-day. And I enjoy it because I think one of the things that I love about dermatology is that my patients get better in front of me, and they see that they get better. So unlike, you know, treating hypertension, where you know that you're treating it, but your patient may not really see the results of it. When you treat someone's acne, they see it, right? And they see it within a few months, and they are so thrilled because it affects their quality of life. It affects their confidence or self-esteem. So classic patient, this patient is a 15-year-old. She came to me because she's tried everything over the counter, and she's not getting better, and she's worried that she's getting some scarring. So what did I use for this patient? Do we use topical retinoids? Does she need antibiotics? Does she need something called Accutane, or is all of that a lost cause? And does she need to use laser? So for her, we did topical retinoids. It's really important to know, again, classically what we're looking at, right? So here, this patient has lots of little blackheads and whiteheads. Topical retinoids are either prescription or there are over-the-counter options. And basically what that does is it turns over that epidermis that you guys saw at the beginning, and it clears out your pores, essentially. They do a lot of other things too, which, you know, we could always get into on a different day, but that's what this patient needs. She needs something to kind of clear those out. Whereas these patients, patient on the left, you can see that they're forming more inflammatory acne. So this is red, right? You're seeing pustules. This guy has really bad scarring acne. This is nodular. This is cystic. So topicals are not going to cut it in these two cases. This patient on the left, if they have never been treated before, I would have done something like an oral antibiotic, something like doxycycline. They're also on a really good topical regimen. We're using washes like benzoyl peroxide. And then this guy on the right would definitely, for me, be started on Accutane, maybe even a little prednisone to actually calm him down. But Accutane is the oral retinoid. It's a version of a topical retinoid like Retin-A. needs monitoring. So we see these patients every month while we prescribe it. We initially have to check their liver, their lipid panel, because it can have some side effects on that. So that's kind of more of a high risk medication monitoring patient, whereas, some of our other acne patients are more topicals and cosmetics. So for the scarring, when this is all medically treated, we have lasers, we have chemical peels, microneedling, lots of different options. So in the middle of my morning, right in the middle, I have a 45-year-old Caucasian female. She wants to talk about anti-aging. She's a non-smoker. She's pretty good about sunscreen use, but she definitely knows that she could be better. And then wants to discuss an anti-aging routine. So first thing that we tell all of our cosmetic patients, I think it's going to be very hard pressed for you to find a dermatologist who does not believe in sunscreen, but we know that sunscreen causes aging. So maybe you guys have already seen this picture before, but I love this photo. I show this to all my patients. This is, I think it was in the New England Journal of Medicine a few years ago. This guy was a truck driver, and you can see how one side of his face, this side right here, was exposed to sun from driving every day. And look at all those changes. Look at all those wrinkles. Look how much older he looks on this side versus this side right here. So two forms of UV radiation. UVA is going to cause more aging. UVB is going to cause burning. So overall, we're not big fans of UV radiation as dermatologists, but UVA is aging. So that's why we tell patients that they need sunscreen. I'm going to tell this patient that she needs a broad spectrum sunscreen daily, 30 to 50, and she needs to reapply it every 2 hours. If she's in her car, if she's by a window, if she's in a room and it's winter and she is not exposed all day, fine. Maybe she doesn't need to reapply, but most of us are not. So you want to reapply every 2 hours, and SPF 30 to 50 is what I definitely recommend. Really quick, how much sunscreen is enough? So we find that most patients do not apply enough sunscreen. So you want to apply a shot glass worth for the entire body, and that's how you're going to get that number on there. How much more time do we have, guys? One of you?
We are a little over the hour, but you can keep going. No worries at all.
Oh, we're over the hour. Sorry, I was trying to go until 12:10. Okay, let me just really quickly kind of speed through, and then that way we have some question time. So for her, we talked about fillers and Botox. This is a classic example of Botox where, we injected crow's feet here, and we got rid of those wrinkles. I see patients all the time. So this is for, our frontal wrinkles right here. And so Botox, Dysport, Xeomin, lots of different brands. This tends to last about 3 to 6 months. So Botox, and then you'll see filler here. Won't go into any of the science since we're running out of time. But if you like cosmetics, if you like aesthetics, dermatology is a great field for you. So we're doing a lot of this. And then let me just get into some of the cosmetic and the surgical stuff real quick before questions, because I know a lot of you are probably interested in that part of it. So lasers, chemical peels, microneedling. Do a ton of this. My entire Thursday afternoon is just lasers. So I have the PDL laser, and then I rent some of these other lasers depending on what my patients need. But this is going to be for photo damage, brown spots, rosacea, hair removal, something that you are trained in within dermatology. Chemical peels are probably one of my favorite procedures. They do so much and they are so cheap for the patient depending on which one you do. But this is something that I actually made for my Instagram, I think last week. But you'll see some of these top peels are really good for like acne. And then depending on the peel, there are different ones that we can use for wrinkles and hyperpigmentation. So again, common practice, easy procedure. But if you're into procedures, you're into aesthetics, just another reason why dermatology is such a great field. And then this might actually be one of my last 2 slides. Procedural dermatology. So I do procedures all day, every day. So if you are not procedural, dermatology is probably, it doesn't mean that it's not for you. I have some, that are, some colleagues that are more medical derm, but every derm is going to need to most likely do some sort of biopsy, whether it's shave biopsies, punches to figure out rash. You don't have to do your excisions, but a lot of us do. I do these every 20, 30 minutes on a Tuesday and anywhere on my normal days. But basically, we'll identify a lesion, we'll circle margins around it. We will cut to subcutaneous fat. we'll cauterize, and then we'll put inside stitches and top stitches. So this is kind of how a normal surgery clinic is for me. And that's, again, why I love derm, because I can do stuff like this in the middle of my day in 20 minutes and cure someone of their skin cancer without having to run off to the OR. So it just gives me a really good mix throughout my day. And that is finally my last slide. So again, here's my contact information. If you have any questions on anything we talked about today, you want to know more about dermatology, how to become a dermatologist, please contact me, and then I will stop talking so that if there's any questions, you guys can ask me.
Thank you so much. This was really informative. There are so many messages in the chat just saying.
Oh, sorry, I went too long.
No, it was so great.
But
Everyone
I'm happy,
enjoyed the
I have
case
time
studies.
if you guys want to stay. I'm happy to answer anything you want to.
Yeah, we can go through, there's a ton of questions, so we can go through and just ask some of the pressing ones. To start off with, earlier there was a question about, when you're working with darker complexions, how do some of these diseases show up in comparison to lighter complexions?
Thank you.
And is it harder to deal with?
Yeah, no, thank you for asking that. I tried to put a few photos of some, darker skin in there, and I think that is so important. Part of your training in dermatology, if you to go to any residency here, is going to be able to identify in both types, skin of color and non-skin of color. So skin of color is definitely something that we learn about and something that's really important. So psoriasis, eczema, they're going to show up as different colors, right? They're not going to show up as bright pink. They may show up more purple. They may show up more tan. So that's important to recognize. What I think is even more important is treatment. So that liquid nitrogen that I was talking about, that cryotherapy, that can leave hypopigmentation, that can leave white spots. So sure, am I going to use that on my 75-year-old Caucasian farmer? Yes. But am I going to use that on my 40-year-old African-American woman? Absolutely not, right? That's going to leave white spots. That's going to leave her scarring. So it's important to talk about those and recognize those when we not only see diagnoses, but talk about treatment options. For my Indian skin of color, there are certain chemical peels that are safe. There are certain lasers that are not. So recognizing that, and then also knowing how to treat that, and then treat side effects of some of the hyperpigmentation and hypopigmentation that we see is really important. So thanks for addressing that.
Great, thank you. There was also a really interesting question that was just asking about if you know, or your opinion about the aspect of AI maybe coming into helping with diagnosing patients in dermatology.
So I think that AI is going to take over a lot of fields. So do I think that AI would have a role in terms of maybe helping us out with like teledermatology, virtual consults, scribing, et cetera, things like that? Yes. Do I think that I know that there are companies that are trying to take over where AI does skin checks and stuff. I'm sure that there will be ways, but I just don't think that it could ever actually replace a dermatologist. So much of what I see needs to be touched. So one of the weirdest things with COVID was, I would love to wear gloves with my patients all day. I would love to do teledermatology, but it didn't work, right? Like I did teledermatology for 6 weeks and it was hard. You can't see the spot well over Zoom. I can't touch that scalp to know that it's scaly. The AI is not going to be able to sit there and do my biopsy for me. So I think with medicine in general, AI is coming. I hope that it will come in a way that it can help us all, make us more efficient, be better for the patient, but I don't think it will ever replace the need for having a dermatologist. So definitely, I think there's definitely still room for it to help us, but I don't think it'll ever replace anything.
Great, thank you so much. There was a question, and you kind of did touch on this a little bit, but could you go over the difference between aesthetic medicine and cosmetic dermatology?
So I think that cosmetic, to me, aesthetic is going to be more I think they're very similar. So I think that there's more skincare routines. I think there's prevention, and then I think there's a lot of procedures, right? So a lot of people will be practicing aesthetic medicine right now. Again, I think it's really important to go to someone who's trained in doing all of this. The way that I practice it, I would love to sit there all day and, talk to my patients about their skincare regimens and their routines and their procedures. I tend to focus on more the procedural part of it. the Botox and the fillers and the lasers. And then we will, very quickly kind of get together a routine for them. So that means like, this is the cleanser I think that you need. This is the sunscreen I think that you need. Do you need a vitamin C serum? Do you need a retinoid, etc.? So I'll usually start them on something like that. And then a lot of dermatologists work with hand in hand with, our esthetician. I have an esthetician in my building, my office, and she's one door down from me. So after I kind of get my patient on what I think is good, I will refer them to her, and she will kind of hone in some of those little things like, hey, you don't need this moisturizer. You don't actually need this serum. And part of that was the reason that my friend and I started our own skincare line. We found that everyone was really confused on what to use, and everyone's using a 12-step regimen that they found on TikTok. And we just wanted to keep it simple. Skincare doesn't have to be expensive. It does not have to be complicated to be effective. So that's what I think of when I think of aesthetic medicine. And then cosmetic to me is more, my procedures to kind of treat some of the stuff that is already a little bit too late, if you will, to not prevent. So I think prevention is the most important part, and then treating with some of our procedures is the next step.
Great, thank you for clarifying that. We also had a really interesting kind of two-part question.
Yeah.
In dermatology, do you often, or how often do you see patient loss directly correlated? And if you do experience any patient loss, how do you cope with that?
Great question. So luckily, not often compared to other fields of medicine. So most of my patients are healthy. They're spot checks, they're acne patients, they're psoriasis. But, definitely melanoma is, we talked about it. It definitely can occur rapidly. And definitely something that I saw, I think, more in residency in terms of patient loss. So these would be the patients that we were managing inpatient that were really, really sick. So in terms of coping, everyone has their own way, right? So for me, that is going to be my support system outside of medicine. So I am I'm a big extrovert. The way that I'm talking to you guys is the way that I talk to my patients. Like I don't, I think it's important. Some people are really professional at work in one sense, and then they are completely different outside of work. I'm definitely professional at work, but my patients, I think, appreciate that I talk to them like I'm talking to you. And so just the other day, I had a patient who I saw for a second opinion. I wish I could pull it up, but probably don't have time. Anyways, he came in with a melanoma. It was from here to here, like literally encompassing his whole shoulder. Came up in a month. He was 80. He came in to see me for a second opinion. He was already on his way to get chemotherapy that afternoon. And I told him that that was probably the right step, right? But rather than shoving him out the door, I sat there with him for 30 minutes and kind of talked to him and his son. And even though I knew that I didn't actually have anything to offer, like just being there for them, just being a human with them, just sitting down and talking to them. And then he actually ended up passing away about a month after I saw him. And the only reason I even found out was he was on my schedule. And his son came in and took his appointment. And the thing with dermatology is, for me, it is very fast paced, right? I am seeing 40 patients a day. So I'm going room to room to room to room. But my patients get that. They know that, I'm not going to sit there and be able to talk to them for 30 minutes. But with this patient, I did, with the son, I sat there, he started crying, I started crying, I held his hand, we talked about his dad. The patients after that knew that I was running late and they understood it, but that's a big part of anything that you go into, right? Whether you're going to become a pediatrician, a dermatologist, you're going to be an oncologist, empathy is such an important part of, I think, having that. You need to have that characteristic if you're going to go to medical school. So having that is important, and it's going to make you an amazing physician. And then coping, for me, it's, just being able to talk to that patient, knowing that he felt satisfied and kind of comforted by what I was able to say, and then coming home and having my, my husband, my son. So I cope with things out of clinic for me. So.
Thank you so much for sharing that.
But luckily not common in dermatology. It does happen. You have to be able to, but no, it's not like I'm a in-word, pediatric hematology oncologist dealing with that kind of stuff all the time. So I am blessed in that sense with what I do.
Yeah, absolutely. There was a question kind of going back to when you were interviewing for residency in medical school. when you're going through that interview process, did you, or is it normal to, explicitly say that you're intending on going into dermatology, or do you want to say, I'm interested in all specialties, just to kind of give like a blanket answer?
I think it's both. So I did not say that in dermatology when I was applying into medical school because I didn't know. I thought I was going to be a pediatric, either cardiologist or hemonc. So if you go back and look at my application, I was gung ho about medicine. Pediatrics. I was the president of my pediatrics club. So I ended up scheduling pediatrics like halfway into my third year because I wanted to be really prepared for it. And I had dermatology, I think like second. So dermatology was one of those electives that I just did and I loved, and I had no idea I wanted to do derm. So for me, I did not say that in medical school. I would probably say that you should not. And I don't mean that if you're like 100% set on dermatology, your mom's a dermatologist, your dad's a dermatologist, you're going to take over their dermatology practice. Don't lie. The biggest thing about interviews is be true to yourself. As someone who's been on both sides of it, I've interviewed and I've been the interviewee, right? Like we can tell when you're not being truthful. So be truthful to yourself. That will always take you the farthest in life. But the only reason I say maybe don't say that is I don't think you know yet. I think I think you can be interested in a field. I think you can love, the procedural aspect of it, the work-life balance of it, but it's just too early to tell. You could go into medical school and like love what a general surgeon does and say, screw work-life balance, or you know what, maybe I'm going to be the general surgeon that does have work-life balance, because there are ones that are out there. So I just think it's too early. So why put yourself in a corner when you don't have to be? I think it's fine to maybe talk about how you're interested in procedures, or you're good with your hands and you have this skill set because you volunteered with so and so, and kind of like highlight aspects of your resume that way. My biggest advice for interviewees is I think find something that makes you unique. Okay, everyone is going to have the volunteer hours. Everyone's going to have a little bit of research, but you need to find something that makes you unique, makes you passionate. The girls that are organizing this, like this is unique. They're going to be able to talk about this. You guys, I'm sure that are listening, have your own hobbies. You have something, but find something unique and really highlight that during your interview. That's what's going to make you stand out, because at the end of the day, everyone else has everything on paper. So paper is important. Don't get me wrong. If you don't have the stuff on paper, you're not going to get the interview in the first place. So it's really important to have all the MCAT and the shadowing and all that. But just don't put yourself in a corner, but be true to yourself.
Thank you. I think that's great advice. I think we will wrap up with one last question. As we are hopefully rolling out these vaccines faster in the upcoming weeks and ending the pandemic, hopefully, is there any advice you'd like to leave us with as pre-med students during a very weird time?
I think that this is great that you guys are doing this in a time where shadowing is probably not, something that is happening. And yeah, I do. I just got my vaccine on Wednesday. I cried. I was so excited. So I definitely think that there's hope at the end of the tunnel. Or light at the end of the tunnel. What's the saying? But basically, yeah, I think that I'm hopeful that by summer, maybe fall, I don't know, we will be back to, letting shadowing come back in our office. So shadowing is a great way to get contacts. Letters of recommendation are really important for medical school. So you're going to meet physicians, you're going to get people for letter of recommendations. You're going to figure out what is right for you. Maybe you will find out that you love derm or that you hate derm, and etc. But just keep volunteering. There's all kinds of ways that you can do volunteer work. You can do research. I'm trying to think of as a pre-med. As a pre-med, I did do research. So one of the good ways to do research, if you're interested in that, is reach out to departments, reach out to people in your school, reach out to medical students that reach out to residents that say, hey, is there anywhere that you need help? Volunteer. So currently and have it be something that you're passionate about, right? Don't volunteer just for the sake of volunteering. When I was in med school, I volunteered with a melanoma group that basically like went around talking to schools and colleges and fraternities about skincare education. So that was fun for me because I liked pediatrics. That's I think how I actually got into it, and then I ended up liking the derm aspect. But right now I volunteer with like an infertility group, but I help plan their fundraiser gala. So just there are tons of opportunities, I think, even with the pandemic, that you can find online. And I think you guys just being here on a Saturday morning shows that you're definitely motivated to do that. So find something, a hobby, spin it in a way that can make you successful, and you'll never regret it.
That's perfect. Thank you so much for being here with us. Thank you for giving us your Saturday morning. This was a great presentation. As I said, so many people were just thanking you so much for these amazing case studies, and it was very informative. So
I'm sorry for the delay again. And yeah, you guys have my contact information. So if you have any questions you feel like didn't get addressed, feel free to contact me.